Thanks very much. Well, I'm not actually going to talk to you too much about technology. I'm going to talk to you about how we need to, in a very much speaking to Dan's point, kind of unleash the power of people, both the patient, the professional, the carer, and some of the extraordinary opportunities that digital offers is key to that. But we mustn't forget for a minute that technology is not an end in itself, and that the objective we all have is to give people much greater control and much more information about the decisions they need to make for a high quality and sustainable health service. And I just kind of, as we race to bring the NHS up to the kind of standard we're beginning to expect in other parts of our lives, whether we're online banking or whether we're booking travel, but a world in which is much more responsive and personalised and engaged with our own individual requirements and needs. As we race to try and bring the NHS to that point, we can already start to see glimpses of ways in which just the future is happening almost regardless of any national policy. And I had an amazing, it was just such a heartening story the other day when we were discussing this topic. So there is a charity in Hull that looks after people who are homeless and tries to get them to engage more with their health. And there was a particular gentleman who was at the time living in a tent on the A63, which is the sort of main road out of Hull. And the charity had been trying to persuade him for some time to come into a transitional hostel. And he'd been quite resistant, and one of the reasons for this was that he was ill. He was not well. He hadn't seen a GP for 7 years. And the reason he hadn't seen a GP for 7 years was because he was, I think terrified is probably the wrong word, but very nervous about making phone calls. And as I'm sure we've all had the experience, booking an appointment with a GP on the Monday morning at the allotted time can be quite a fierce and aggressive conversation. And for this particular gentleman, as I think for many people, that kind of forceful, self-assertive conversation is quite difficult, and he just decided he didn't want to get involved. So for 7 years had not engaged with his GP, and as a result was getting ill. He eventually did agree to move into this hostel, and the charity, which is one of our partners in delivering a very important program which helps very disadvantaged people learn how to use the internet, invited him to join that program. We call that Widening Digital Inclusion, and already that program has helped support 200,000 people in this country learn very, very basic things about accessing the internet, how to send an email, how to make better use of NHS choices, and so on. And so he hadn't ever used a computer before, certainly didn't know how to send an email, and he was really interested. So he learned, there was a kind of coaching scheme, learned quite quickly, of course, how to access the internet, and realized that he was able to book an appointment with local GPs online, as is now the case for about 90% of practices in this country. And he chose to exercise that option. That alleviated the need for him to make a phone call, and he found that a much better arrangement for his particular requirement. And he also sent an email to the practice to explain what he wanted out of meeting the GP. Anyway, the net result is this chap has become an incredibly active consumer of healthcare, most of it digital. He has seen the GP on a number of occasions. He's much better. He's out of his tent. And I just think that's what this is all about. That this is not about infrastructure or the cloud. It's about the outcome for real people in our real world who are struggling really in some very complex circumstances with their own health, their own lives. And that's what the objective is. So the 5-year forward view, which Dan mentioned, is absolutely focused on that objective. It is about creating the circumstances for individuals in our society and local communities to be healthier, to take more control, to engage in a much more sustainable way with health services. And a really important commitment, which I hope you will have noticed in the forward view, is to the role that digital tools, better information, more transparency, more personal participation can play. In fact, there's a whole chapter dedicated to that commitment. And in the wake of the 5-year forward view, the National Information Board, which I chair, put a whole bunch more flesh on the bones of those commitments to start teasing out what it all really means. And I will briefly talk about what the priorities we are now saying the health and care community at large needs to rise to. So just before I do that, how many people in this room have even heard of the National Information Board framework or have read it? Okay, so quite a few. Can I just encourage if you have any interest at all in this space, which you obviously do since you're here, it is worth reading, because for the first time this government has committed to a range of, I think, very, very radical and paced proposals to deliver a real change for patients and citizens in the way in which the health service and, well, more broadly, the health and care system interacts with them. And the first really important area of that focus is in relation to data and transparency. So Dan touched on that a little bit, but essentially we are, as a system, in large part flying blind in relation to the quality of care we provide to our patients. We have some insight, but for example, today we cannot count the number of people who are treated for chemotherapy, nor have any proper insight into the quality of their outcome. This is just an absence which needs to, for moral as well as clinical reasons, be filled with real urgency. And the pace with which the Secretary of State and Dan and other colleagues in this government have focused on filling those gaps has been remarkably, I think, reassuring that there's no doubt, nobody has any doubt of the importance of better data supporting better clinical outcomes for patients. So a really big and important priority is just to get that data to flow in ways that, of course, that are safe, absolutely prioritise confidentiality. Programs like Care.data is an example of an area where we're being very thoughtful indeed about how we can deliver, on the one hand, the benefits that linking GP and hospital data together will bring for a whole range of different reasons, including direct patient care, but balancing that with some very important safeguards around the way in which, in a way, a new deal will be done between the NHS, the citizen individually, as to what uses their data will be put to and for what benefit. So we're building a kind of a whole new narrative around the importance of data and data sharing, and it's not just data related to clinical outcomes or clinical records, but another vitally important kind of data which the NHS in England is pioneering, I think also offers enormous opportunities, particularly for cloud-based big data analytics, to really add value to clinicians, sort of the management information clinicians have about their patients, and that's the friends and family test. And again, I hope people will be aware of this, but it's been a sort of small but really important miracle in the middle of the health service over the last year. We are inviting, offering, in fact requiring in hospitals and now general practice, patients to be given the chance to rate the experience they've had, and from this April also to be offered the opportunity of delivering a free text comment, rather like TripAdvisor. And since that offer was made back in April last year, more than 5 million people, we'll pass that mark this month, have contributed a rating and a comment. Most of them have made comments. It's an astonishing sort of symptom of a social movement that's gripping the health service, and I think a really reassuring example of ways in which people really do want to get involved with it, as Dan was saying. This NHS of ours should and is really a social movement, and that social movement can be much better enabled by better data sharing and the sorts of digital tools that we'll discuss in a second. So there's friends and family test, we've got routine data, but crucially also the importance of that data being presented very accessibly in comparative formats to enable doctors, first of all, to be able to hold themselves to account, or clinicians more widely, but also critically to deliver a different kind of accountability to us as service users, as citizens. And that's an accountability we've got used to in so many other parts of our routine lives, and yet still, to some extent, is absent from the health service, which is why My NHS, a programme very much led by the Secretary of State himself, I think is such an important first step in the direction of a truly open, engaged, data-based, evidence-based health service. Now again, how many people in this room have come across My NHS? Yeah, okay, so it hasn't been particularly promoted, but you will be surprised what it offers. And over the course of the next year, it's going to be substantially enhanced. If you go to www.nhs.uk/MyNHS, you'll find it. And it essentially is the world's first really comprehensive comparative search engine for local service outcomes. And you can compare all kinds of data from quality of food, safety in hospitals, GP practice outcomes, and so on, public health outcomes for local communities in a way that just hasn't been possible before. So it's a kind of, I think, an important first step towards a future of which we which we want, which is of an open, fully transparent service engaged in an evidence-based conversation about quality across the piece. And on the same transparency and data theme, I think for those who are looking a little bit ahead, the NHS also needs to start, and is starting to think about how it can future-proof itself, how it can offer its patients maximum advantage from the emerging science of genomics, molecular pathology. So we move from a world in which data has largely meant information derived from clinical records, other sources, to help inform service design and delivery, to a world in which an exponentially larger volume of data, quite literally about the real-time interaction of our molecules with our genes and other external factors, will determine, in many cases, the appropriateness of a clinical intervention, and with that, the advent of truly personalized medicine. And if I was interested in data, running a business that was looking at the opportunity of the cloud, this is an area that needs proper focus in this country. The idea of how do we begin to take proper advantage of that very different data-based healthcare of the future. So here we've got some great opportunities, and as you see from the National Information Board framework, some proposals around how we will start to build an approach to dealing with both the future and deliver on the present. The second sort of core operating theme, if you like, of both the 5-year forward view and the National Information Board framework is around participation. And this is a very broad concept, which really is about giving people much more control over their own health and their own care where that's appropriate, but also it's about thinking differently about involving the informal workforce, the carer community, those on whom we rely fundamentally for delivery of health services, and how we engage everybody with delivery of healthcare in ways that are suitable for them. So here we have some very important, again, unprecedented commitments to do things like, from this spring, offer every citizen that wishes it access to their own GP record. It's a really important and real commitment. I was with the BMA yesterday. They're actually very excited by the idea that they will be the most pioneering primary care workforce in the world. There is no other country which offers its citizens comprehensive access to their general practice or equivalent record. Now that's just the beginning, and the National Information Board is committed to offering a very similar real-time online access across the board for all records by 2018. And not only that, but we're saying, having listened really hard to colleagues in the voluntary sector and elsewhere in the advocate community, and more broadly actually just in civil society, having listened really hard, we've heard that patients and people want the ability to write into their own records. They want parity with their clinician. They want their views to have a place in the way in which clinical judgments are made about their treatment. So we are going to create the offer to citizens by 2018 that they will be able to write into their own records. Of course, not edit the clinical view that's recorded there, but to add to it, to have parity with it. We think that this will prove to be a kind of an industrial moment. That's the way the 5-year forward view framed it. A moment in which the entrepreneurial community, we hope, will create a very diverse and engaged set of tools that will help people derive real value from their own data. And in a very kind of conceptual, almost philosophical way, all of this is about giving individuals the opportunity to really extract value from themselves in a way that will promote their healthy life outcomes. So that's one big side of it. Giving people control means giving them access to their own data. It also means giving them access to some really meaningful transactions. So we want them to be able to book appointments online comprehensively. We want them to be able to get access to prescriptions and lab test results, and pretty much kind of offer online banking style engagement for local health services. That again comes this year for all GP practices. But in addition, we've identified 3 or 4 really important areas where we just need to move more quickly, even than that. And those 3 areas, I won't go into any detail on them, but again, these might be interesting areas for you to think about getting involved in. The first of those is mental health. We know, and the evidence is absolutely clear, that digital tools have real therapeutic value in the management of mental health disorders, actually quite widely across the whole spectrum of mental health, but particularly for those with mild to moderate mental illness. GPs already are able to prescribe some cognitive behavioral therapy digital tools. Truth is, they're not good enough, and we need a whole new class of digital services for mental health patients. So we're going to launch a variety of competitions over the next few months with a view to establishing the first app store on NHS Choices from which you will be able to download NHS accredited mental health services, digital services. We will also be encouraging GPs to refer their patients to those services where it's appropriate, and in a way using the marketing muscle of the NHS to drive more awareness for the public of really high quality digital tools that we think will give them more control and also help them to be more measured in their own use of physical health services where that's appropriate. That's the first area. The second area relates to end-of-life care, where again there's a big demand from people for the ability to in real time record preferences for treatment at the end of their lives, and for those preferences to be respected by carers. There's been a very successful experiment in London which has hugely driven up the number of, or has enabled many more people to die at home when they wished to, reduced the stress on local services, and grossly improved the, if I can put it like this, the outcome for relatives at the end of people's lives. So we're going to roll out that offer across the nation quickly as well. And then finally, in a similar way, we hear from mothers that they want a digital relationship with their child's health. They currently, of course, have the Red Book. About 10% of those are lost each year, with not devastating, but really frustrating consequences for parents. So another simple and easy way in which we can improve the offer that the NHS makes to people, and again, improve the degree of control they have in improving their own circumstances, is through a digital version of that. And then finally, the third key theme of the framework, which in many ways arguably is immediately the most important, is around what I call collaboration, but you'll know as interoperability. And this is about finally drawing a line in the sand and forever banning the fax machine from NHS practice. It is a dangerous culture we often operate in. Junior doctors are at risk of misdiagnosis, of prescribing the wrong drugs, because only 12% of hospitals in this country run basic e-prescribing tools, which we know, again, with really clear evidence, reduce dramatically the incidence of misprescribing on the wards at night. And crucially also, we know that those kinds of tools increase the amount of time frontline staff are able to spend with their patients and reduce, at the moment broadly, if I've got this right, about junior doctors in a recent survey said they spend about 60 to 70% of their time in administration. We know that digital environments reduce that requirement very considerably. So interoperability, and just this sounds ambitious, it is ambitious, but it is an agreement that has been reached across the health and care system. So the regulators, the commissions have all agreed with these dates, and now it is government policy that by 2018 there will be full digital interoperability in all primary, urgent and emergency care services. So that means that every ambulance in this country will, in real time, be able to access your GP record and your hospital record, if appropriate, when they land at the side of the accident by 2018. That will have happened by then. In fact, already a third of accident emergency services, for example, have interoperability with GP practices now. So we're getting there, but we will have completion of that by 2018. And by 2020, all NHS-funded services will be fully interoperable. And you can imagine the kind of challenge that does present, but a line has got to be drawn in the sand, and proof of the commitment that we are making here is that the current standard contract, which applies to NHS-funded organisations, does for the first time require a series of core digital standards to be met as a core part of the basic licence to operate in our health service. So I'm just going to leave it there, I think, and just invite people. I'm sure Dan and I've got a few minutes for questions, but I really welcome your support in delivering the digital future that will indeed unleash the power of people in our health service. Thank you very much.
Hi, I'm Bhupinder Kohli. I'm a GP in Newham. Tim, I'm very excited about what you said, and I'd like to think in Newham we're doing a lot of what you are saying. We're doing more interoperability than most other people I've heard of. For instance, our urgent care centre is completely connected up to all of our GP practices, so anybody coming in has pretty much access. All but one practice has agreed to do that data sharing, and we've got a number of other projects going. But one of the things that we're trying to push now is patient access and the digital banking or the digital health solution. And one of our frustrations is with your current model is that you're promoting a very wide competitive market. Sounds great. But it means that patient might have to have an app for their pharmacy, a separate app for their Red Book, a separate app for their EMIS GP record, a separate app for their hospital Cerner record, and so on and so on. And I'm not quite sure how that links up, and quite interested to hear your views of your solution, because patients want to go to one place, and another part of that is we're obviously very interested in the consents and the digital consent models. And we're keen that we hand that control back to the patients rather than having queues and queues of patients or huge amounts of dictates from government asking GPs to collect consent codes, which patients do often change. And so they're all linked in many ways. It's a long question, I'm sorry, but what I kind of envisage is a patient health record, which is digitally accessible with their consent model available, which is co-sponsored by the NHS.
Well, so one, the point you raise about the idea that there are 1,000 flowers blooming on the back of this open platform. So essentially, what we're really doing is saying we're going to create a set of sort of open APIs, if I can use that technical jargon, on the back of the NHS, so that developers, entrepreneurs, voluntary organisations can build tools for patients and citizens to extract value from it. That's essentially what we're doing. Now, my own personal view is that it's really important we do allow 1,000 flowers to bloom, and that we do actively encourage entrepreneurialism right across the piece, not necessarily for profit, but absolutely across the piece. And we don't know what the future looks like. And I think there might be quite a lot of patients that actually would quite like a larger number of different tools, and not necessarily them all consolidated into one big fat place. But on the other hand, you look at the world of online banking, and let's be clear, online banking is not equivalent to online health. It's an interesting analogy. There are lots of reasons why it's not really comparable, but it is true that in online banking, we have tended, as consumers, to prefer a consolidation. So we just have a few large banks, and we tend to do everything connected with financial services, one of them. Now, that may be the model that we get to in the end in health, but my feeling is we have to sort of let it develop and not constrain it. And I mean, I had a really interesting conversation yesterday with some of the great advocates, maybe some of them in the room, for open source and Code for Health, which is another initiative we're launching, where we're going to be offering staff in the health service the chance to learn how to code up apps and become developers. And for sure, some of them, I'm convinced, will want to present those apps to the general public, develop them maybe even as businesses. So it's a conundrum, and I think in a way we're just going to have to see how it develops as time goes by, because the other very important thing, which I didn't mention, is that I think there's a very, very important responsibility for the NHS to be a driver of economic growth, particularly in these difficult social circumstances we're in. And a big area where I think it can make a contribution is by helping support the development of lots and lots of businesses, driving real value for patients out of these vast data and digital assets that the health service has got. So it's a point of view, I suppose.
Could Dan add to that before he goes?
Yeah.
No, I mean the one thing I wanted to probably pick up on, which was the point also from the last question as well, was that it's absolutely right that we've got to be very careful about how data is used, and there is always the option for people to opt out of their data being shared or used. There were a number of additional safeguards we brought in earlier this year, that if there is misuse of data, that an organisation that misuses data will not be allowed, one strike and you're out, we won't be allowed to use data again. We've now got in place Fiona Caldecott as the National Data Guardian, who is working to make sure that data in the system is always used appropriately. But there is a duty on the NHS to share data, and it happens every day now, and it should happen more within those confines of confidentiality, because it's about delivering direct care to patients effectively. The patient, for example, the person who is in a care home at the moment, who has dementia, who perhaps can't speak for themselves about what is wrong with them, who arrives in A&E, it would very greatly assist the A&E doctor or the ambulance to actually understand a bit more about that patient in order to be able to deliver direct care more effectively. Now, the system does, in many cases, the health system, share direct data effectively, but we do need to see greater interoperability of the systems in the health service. That's why the standard contract was changed, so that care providers can the different IT systems, the different parts of the system use, can better communicate with each other, and that will lead to the better provision of direct care for patients, and it will save doctors and nurses time, because they won't be phoning to try and find out or try and speak to somebody who knows something about the patient. They'll actually have the data available for them there, so they know if they're allergic to penicillin, they'll know more about their medical history, and particularly with frail, vulnerable people or people with dementia, that's a huge advantage, and something that does happen already in many parts of our health system, but needs to happen more, but as long as those safeguards are put in place. So the key, if you like, to meeting some of these challenges, and notwithstanding the issue on apps, is having that greater interoperability between systems, and all providers actually making sure that they do implement that contract and the requirements in that contract with greater vigour, and obviously in terms of the future of confidentiality, we would like to see, and I think there's a cross-party agreement on this, that the Data Guardian is put onto a statutory footing with further powers to oversee the security of data in the future, which I think will be very reassuring to people who are worried about any potential abuses, though there are already very strong safeguards in the system.
Hi, Tim. Phil Wainwright from Diginomica. I was very interested when you were talking about data analytics and being able to analyse healthcare data both across the population and also relating to individual patients. And it resonated with me because I recently spoke to the head of Philips' new healthcare informatics division, and they're actually building a completely new data store that allows them to collect data from all the various devices that can take in data from patients, and then match that to other genomic information and so on, and the healthcare record, to be able to help with their care, particularly patients with chronic conditions. And so you talked about letting 1,000 flowers bloom, the thing that when you were talking I was thinking about was making this interoperability work. I mean, there needs to be innovation, but there also needs to be some kind of standardization going on to make sure that all of this is going to work. So I wonder, are you going to be quite hands-on with looking at what people are doing? You don't want to to regulate too soon, but at the same time, you can't have too much diversity in standards, otherwise you won't get the interoperability.
Yeah, so no. I mean, I'm not quite sure I understand the question, because what absolutely there can be no diversity in standards. So the standards are absolutely crystal clear, extraordinarily detailed. So we are, for example, going to mandate the adoption of SNOMED CT across the system. That is a very detailed. That means, in the unpacking of it, some very detailed, specific standards which are not variable, and which allow for communication. We're mandating the electronic discharge protocols which the Royal College of Physicians have developed over many years, and a variety of other small number of GS1 barcoding would be another standard. So a small number of absolutely non-variable standards. And indeed, to have the privilege of being funded to receive an NHS patient, you will have to meet those standards by 2018 or 2020. So that's a sort of basic. There's a slightly different issue about, on the back of those standards and the flows of data that those standards enable, a diverse and exciting sort of industry emerging, which will meet the very varied requirements of all of our society at large, whether those are for life sciences or individual patients or. And I'm very, very reluctant to impose any constraint whatsoever, other than confidentiality, consent, and all the legal requirements we've got. But any consent really on the way in which people take advantage of some of these data assets when it's permitted. And a really good example would indeed be, one of my responsibilities is to manage the programme in the NHS on genomics. The Prime Minister, I'm sure you know, has challenged, indeed funded the NHS to sequence 100,000 whole human genomes by 2017, an enormous undertaking. And one of the biggest challenges there is going to be, in order for that kind of pilot study really to offer proper clinical value, we need to find a way of helping the NHS extract from itself whole new types of what is called phenotypic data, data about people, very different to the kinds of data often that's collected in the conventional medical record, and enable it to be linked to the gene data so that clinical value can be derived. Now, this has implications for all sorts of things, storage. This is vast, exponentially large data. I think that there'll be lots of different people who will offer different sorts of solutions. And at the moment, I don't want to restrict those offers because no one really knows what the right approach long term will be. And I know of a number of organisations who are doing what you've just described Philips are doing, and I think that's great. Now, it may well be that some will succeed and others won't, because actually it turns out that the particular approach they've taken doesn't quite work, but we just don't know at the moment. So whilst we will have an absolute focus and discipline around the core standards, and indeed about the permissions that enable people to access any data that flows from that interoperability, I'm very keen on a diverse, innovative marketplace which will support the development of a modern health service over time.